I want to ask you something. How many of the following do you have? A waist circumference that has been creeping upward for years. Blood pressure that sits above 130 over 80. Fasting blood glucose that your doctor describes as borderline or slightly elevated. Triglycerides that are above 1.7 millimoles per liter. HDL cholesterol that is below 1.0 in men or below 1.3 in women. If you have 3 or more of those 5 findings, and a significant proportion of adults do, you meet the clinical criteria for metabolic syndrome. And metabolic syndrome is not 5 separate problems. It is one problem, expressed through 5 different measurements, driven by a single underlying mechanism. Metabolic syndrome affects approximately 1 in 3 adults in most developed countries. In some populations and age groups, the prevalence approaches 1 in 2. It is the most common medical condition that most people have never heard diagnosed. People are told separately that their blood pressure is a bit high, their sugar is borderline, their triglycerides are elevated, and their waistline is concerning. But they are rarely told that these 5 findings are not coincidences. They are expressions of the same underlying metabolic dysfunction, and they are driving the same cascade of disease risk simultaneously. If you have watched previous videos in this series, every condition we have covered, high blood pressure, kidney disease, type 2 diabetes, heart disease, stroke, high cholesterol, fatty liver disease, sleep apnea, has appeared against the backdrop of metabolic syndrome as a driving or amplifying force. In this video, I want to go one level deeper. I want to explain exactly what metabolic syndrome is, what causes it at a biological level, why the 5 criteria cluster together, what it does to your health over time, and most importantly, the evidence-based protocol for reversing it. Because metabolic syndrome, caught at any stage before advanced organ damage, is entirely reversible. That is the message I most want you to leave this video with. By the end of this video, you will understand metabolic syndrome in a way that most adults with it never do. You will know the 5 diagnostic criteria, what they mean individually and collectively, the biological mechanism connecting them, the organs they damage over time, and the 8 evidence-based actions that address all 5 criteria simultaneously. Let us get into it. Metabolic syndrome is a clinical diagnosis made when a person has 3 or more of 5 specific metabolic abnormalities simultaneously. The diagnostic criteria used by the International Diabetes Federation and the American Heart Association are: first, abdominal obesity, a waist circumference above 94 centimeters in men and above 80 centimeters in women in European populations, with lower thresholds for Asian populations. Second, elevated triglycerides, above 1.7 millimoles per liter or on triglyceride-lowering medication. Third, reduced HDL cholesterol, below 1.0 millimoles per liter in men or below 1.3 in women. Fourth, elevated blood pressure, above 130 over 85 or on antihypertensive medication. And fifth, elevated fasting blood glucose, above 5.6 millimoles per liter or on glucose-lowering medication. I want to be very clear about something that most clinical explanations of metabolic syndrome fail to emphasize sufficiently. These 5 criteria are not 5 independent problems that happen to co-occur. They are 5 measurable consequences of a single underlying mechanism: insulin resistance combined with visceral adiposity and the hormonal and inflammatory cascade they produce together. Understanding this is the key to understanding why treating each criterion in isolation, a blood pressure medication here, a statin there, a metformin prescription for the glucose, without addressing the root cause is fundamentally insufficient. Metabolic syndrome is not merely a collection of risk factors, it is a risk multiplier. Having metabolic syndrome doubles the risk of cardiovascular disease and increases the risk of type 2 diabetes 5-fold compared with people who have none of the 5 criteria. Having all 5 criteria simultaneously multiplies cardiovascular risk far beyond the additive contribution of each individual factor. And the risk compounds over time. The longer metabolic syndrome remains unaddressed, the more atherosclerosis accumulates, the more insulin resistance deepens, and the more organ damage accrues in the heart, kidneys, liver, and brain simultaneously. Most people with metabolic syndrome have never been told they have it. Their individual measurements are addressed in isolation: blood pressure managed, glucose monitored, cholesterol treated, without the unifying diagnosis being made or communicated. This matters clinically because metabolic syndrome as a diagnosis carries specific treatment implications that go beyond managing individual criteria. It identifies the person as requiring aggressive lifestyle intervention targeting the shared root cause, and it signals the need for regular monitoring across all 5 criteria and their downstream consequences. The central driver of metabolic syndrome is visceral adiposity, the accumulation of fat in and around the abdominal organs. Visceral fat is metabolically active in a way that subcutaneous fat, the fat under the skin, is not. It continuously releases free fatty acids into the portal circulation, the blood vessel system that drains directly into the liver. It secretes inflammatory cytokines, interleukin-6, tumor necrosis factor alpha, and others, that drive systemic low-grade inflammation. It releases adipokines, hormonal signals from fat tissue that interfere with insulin signaling in muscle, liver, and fat cells. And it releases resistin and leptin in dysregulated amounts that further promote insulin resistance and appetite dysregulation. The cascade from visceral fat leads directly to insulin resistance, the central metabolic dysfunction of metabolic syndrome. When cells become resistant to insulin's signal, the pancreas compensates by producing more insulin. Elevated insulin drives several of the 5 criteria simultaneously. It promotes sodium retention in the kidneys, raising blood pressure. It stimulates VLDL production in the liver, raising triglycerides and lowering HDL. It promotes further visceral fat storage, worsening the original driver. And as the pancreas eventually struggles to compensate, fasting glucose begins to rise. One mechanism, 5 measurable consequences. The liver sits at the intersection of this entire cascade. Excess free fatty acids from visceral fat flood the portal circulation. Elevated insulin drives hepatic de novo lipogenesis, the conversion of excess carbohydrate to fat. The result is hepatic steatosis, fatty liver, which we covered in video 8. A fatty liver further worsens insulin resistance by impairing hepatic insulin signaling, creating a self-reinforcing bidirectional relationship. The liver also produces excess VLDL in response to insulin resistance, which is the primary driver of the elevated triglycerides and low HDL that appear as 2 of the 5 metabolic syndrome criteria. Chronic low-grade inflammation is both a cause and consequence of metabolic syndrome. Visceral fat is an endocrine organ that produces inflammatory cytokines continuously. These cytokines activate inflammatory pathways, particularly NF-κB signaling, throughout the body. In blood vessels, this produces endothelial dysfunction and accelerated atherosclerosis, the mechanism linking metabolic syndrome to the cardiovascular events we covered in videos 5 and 6. In the brain, it produces neuroinflammation that drives cognitive decline. In the kidneys, it drives glomerular inflammation and progressive CKD. Systemic inflammation is the common pathway through which metabolic syndrome translates into multi-organ damage. The hypothalamic pituitary adrenal axis, the body's stress response system, is chronically dysregulated in metabolic syndrome. Elevated cortisol promotes visceral fat accumulation, drives insulin resistance, raises blood pressure, and impairs sleep quality. Sleep disruption worsens cortisol dysregulation. Cortisol dysregulation worsens insulin resistance. This creates a self-reinforcing cycle between metabolic syndrome, sleep apnea, which we covered in video 9, and chronic stress that cannot be broken by addressing any single component alone. Metabolic syndrome rarely produces dramatic symptoms. Its warning signs are subtle, accumulate slowly, and are almost universally attributed to aging or lifestyle rather than a diagnosable medical condition. Here are the 7 most important. The most clinically significant early sign of metabolic syndrome is an increasing waist circumference, even when total body weight is relatively stable or increasing slowly. Many people notice their clothing fitting differently around the abdomen, or a gradual but persistent increase in belt size without significant changes in scale weight. This pattern reflects a shift in fat distribution from subcutaneous to visceral, the metabolically active fat around the organs that drives insulin resistance and inflammation. Waist circumference above 94 centimeters in men or 80 centimeters in women is a diagnostic criterion for metabolic syndrome and should prompt investigation regardless of BMI. As I covered in the diabetes video, post-meal energy crashes, profound fatigue arriving 30 to 90 minutes after eating, particularly after carbohydrate-rich meals, are a direct marker of insulin resistance and dysregulated glucose metabolism. In metabolic syndrome, exaggerated post-meal glucose spikes followed by reactive hypoglycemic dips produce the energy roller coaster that most people attribute to the quantity or composition of their meal rather than to their underlying metabolic function. This pattern, consistently experienced over months or years, is a reliable early marker of progressive insulin resistance. Leptin resistance, which develops alongside insulin resistance in people with metabolic syndrome, impairs the brain's ability to register satiety signals from fat tissue. The result is persistent hunger and carbohydrate cravings that are disproportionate to actual caloric need. People with metabolic syndrome often describe feeling hungry within an hour of eating, having intense cravings for sugar or refined carbohydrates in the late afternoon, and struggling to feel satisfied after meals. These are not character flaws or lack of willpower. They are physiological consequences of leptin and insulin resistance that resolve as metabolic health is restored. Two skin signs are particularly associated with metabolic syndrome and chronically elevated insulin. The first is skin tags. Small, benign growths of skin, typically found on the neck, armpits, and groin, which grow in response to chronically elevated insulin, stimulating skin cell proliferation. The second is acanthosis nigricans, the dark, velvety skin patches and skin folds that I described in the diabetes video, which is a direct visual marker of insulin resistance. Both signs, particularly when found together, should prompt metabolic screening in any clinical consultation. Hypertension in the context of metabolic syndrome has a specific mechanism. Elevated insulin promotes sodium retention in the kidneys through direct action on the renal tubules, increasing circulating blood volume and blood pressure. Insulin resistance also activates the sympathetic nervous system and the renin-angiotensin-aldosterone system, further elevating blood pressure through arterial vasoconstriction. A person with hypertension who also has central obesity, elevated triglycerides, and impaired fasting glucose almost certainly has metabolic syndrome as the underlying driver of their blood pressure elevation. And treating the blood pressure without addressing the metabolic root cause will require progressively higher medication doses as the underlying dysfunction worsens. Many people with metabolic syndrome have fatty liver disease detected incidentally, on an ultrasound performed for a different reason, or through mildly elevated liver enzymes on a routine blood test. As I covered in video 8, fatty liver is present in approximately 70 to 80% of people with metabolic syndrome. Its presence is both a consequence of the underlying insulin resistance and a driver of further metabolic dysfunction, making it an important diagnostic marker and a treatment target in its own right. Any incidental finding of fatty liver should prompt a full metabolic syndrome assessment. The bidirectional relationship between metabolic syndrome and sleep apnea, covered in video 9, means that waking unrefreshed and excessive daytime sleepiness are common features of metabolic syndrome through two independent mechanisms. First, the direct effect of sleep apnea, which is present in a high proportion of people with metabolic syndrome. Second, the effects of insulin resistance and cortisol dysregulation on sleep architecture, which reduce slow-wave and REM sleep even in the absence of formal sleep apnea. Any person with metabolic syndrome who experiences poor sleep quality should be screened for OSA and have their sleep assessed as a component of metabolic syndrome management. The cardiovascular consequences of metabolic syndrome are the most extensively studied and the most severe. Metabolic syndrome doubles the risk of major cardiovascular events, heart attack and stroke, and increases cardiovascular mortality by approximately 1.5 times compared with people without it. The mechanism is the acceleration of atherosclerosis through multiple simultaneous pathways. Elevated small dense LDL from insulin resistance and high triglycerides, endothelial dysfunction from chronic inflammation, hypertension damaging arterial walls, and the prothrombotic state promoted by elevated insulin and inflammation. Metabolic syndrome increases the risk of developing type 2 diabetes fivefold. In people with metabolic syndrome, the pancreatic beta cells that produce insulin are under chronic stress from the demand to compensate for insulin resistance. Over years, beta cell function progressively declines. Fasting glucose rises from borderline to impaired fasting glucose to full type 2 diabetes. Once overt diabetes develops, the cardiovascular and microvascular risks of metabolic syndrome are compounded by the additional damage of chronic hyperglycemia, making diabetes prevention in people with metabolic syndrome one of the most clinically important interventions available. This is the consequence of metabolic syndrome that most people do not know about. Metabolic syndrome is associated with a significantly elevated risk of multiple cancers: breast cancer, colorectal cancer, endometrial cancer, pancreatic cancer, and hepatocellular carcinoma, among others. The mechanisms include the proliferative effects of chronically elevated insulin on tumor growth pathways, the pro-inflammatory environment that promotes tumor initiation and progression, and the hormonal dysregulation, particularly estrogen excess from aromatization in visceral fat, that drives hormone-sensitive cancers. The cancer risk from metabolic syndrome is an underemphasized but clinically important reason to treat this condition aggressively. Metabolic syndrome is now established as a significant risk factor for both vascular dementia and Alzheimer's disease. The mechanisms include accelerated cerebral small vessel disease from hypertension and diabetes, neuroinflammation driven by systemic inflammatory cytokines, and the emerging evidence that insulin resistance in the brain, sometimes called type 3 diabetes, directly impairs neuronal glucose metabolism and promotes amyloid accumulation. The dementia risk associated with metabolic syndrome is not a distant concern. The pathological processes begin decades before cognitive symptoms appear. Diagnosing metabolic syndrome requires 5 measurements. Waist circumference, taken at the midpoint between the lower rib and the iliac crest, not the narrowest point of the waist. Fasting triglycerides, from a standard fasting blood test. HDL cholesterol, from the same blood test. Fasting blood glucose, or HbA1c as a surrogate. And blood pressure, ideally measured after 5 minutes of rest, seated, using a validated monitor. All 5 measurements are available from a standard annual health check and a home blood pressure reading. If you have not had all 5 measured in the past year, that is your starting point. Given the high prevalence of fatty liver and metabolic syndrome, I recommend that ALT and AST are also measured at baseline, with calculation of a FIB-4 score to assess liver fibrosis stage. This adds 2 values to a standard blood test and takes seconds to calculate, but identifies the subset of people with metabolic syndrome who also have significant hepatic fibrosis and who need more aggressive management and hepatology referral. Once metabolic syndrome is identified, annual monitoring of all 5 criteria is essential, both to assess treatment response and to detect progression toward type 2 diabetes or more advanced cardiovascular disease. Blood pressure monitoring at home using a validated cuff provides far more clinically useful data than occasional clinic measurements. HbA1c should be measured annually to track glucose trajectory. Waist circumference is the most sensitive single measure of visceral fat reduction and should be the primary physical target metric, more than scale weight. These 8 actions address all 5 criteria of metabolic syndrome simultaneously. They are not parallel tracks. Each action improves multiple criteria through shared mechanisms. The synergistic effect of combining all 8 produces outcomes that are far greater than any individual intervention. Waist circumference reduction is the primary target metric for metabolic syndrome reversal because it directly reflects visceral fat loss, the root cause of the condition. A 10% reduction in waist circumference produces clinically meaningful improvements in all 5 diagnostic criteria simultaneously. This can occur with modest total weight loss, 5 to 7% of body weight, when that weight loss comes from visceral fat. Measuring waist circumference weekly provides immediate, motivating feedback on whether dietary and exercise interventions are reaching their target. Weigh yourself if you wish, but measure your waist with a tape measure and track that number as your primary outcome. As I have covered across multiple videos in this series, the dietary pattern most directly driving metabolic syndrome is high fructose consumption, primarily from sugary drinks, fruit juice, and ultra-processed foods, combined with low fiber intake. Fructose is processed exclusively in the liver and drives hepatic de novo lipogenesis, raising triglycerides and worsening insulin resistance. Eliminating sugary drinks and reducing ultra-processed food to below 20% of caloric intake produces measurable improvements in triglycerides within 2 to 4 weeks, and improvements in fasting glucose and blood pressure within 6 to 8 weeks of consistent adherence. For metabolic syndrome specifically, the exercise dose that produces meaningful improvements across all 5 criteria is at the higher end of standard recommendations, 200 to 300 minutes of moderate aerobic exercise per week, rather than the minimum 150. At this dose, exercise reduces triglycerides by 15 to 25%, raises HDL by 5 to 10%, lowers systolic blood pressure by 4 to 9 millimeters of mercury, reduces fasting glucose by improving insulin sensitivity, and produces visceral fat loss independently of total calorie restriction. The most effective exercise modality for metabolic syndrome is a combination of aerobic and resistance training. Aerobic for triglyceride reduction and blood pressure, resistance for insulin sensitivity and muscle glucose uptake. Refined carbohydrates, white bread, white rice, pasta, pastries, breakfast cereals, and all ultra-processed snacks produce rapid postprandial glucose spikes that demand high insulin responses, deepen insulin resistance over time, and drive the small, dense LDL phenotype that worsens cardiovascular risk in metabolic syndrome. Replacing refined carbohydrates with fiber-rich alternatives, legumes, whole grains, vegetables, and fruit, reduces postprandial glucose excursions, lowers triglycerides, improves HDL, and reduces the atherogenic LDL particle pattern that characterizes metabolic dyslipidemia. This is not a low-carbohydrate diet prescription. It is a refined carbohydrate reduction strategy that any dietary pattern can accommodate. The bidirectional relationship between sleep and metabolic syndrome makes sleep optimization a clinical priority rather than a lifestyle recommendation. Insufficient sleep, fewer than 6 hours, worsens all 5 metabolic syndrome criteria through elevated cortisol, impaired insulin sensitivity, increased ghrelin, and reduced leptin-producing appetite dysregulation, and elevated sympathetic nervous system tone, raising blood pressure. Treating obstructive sleep apnea, which is present in a high proportion of people with metabolic syndrome, produces significant improvements in blood pressure, particularly in treatment-resistant cases, and improvements in insulin sensitivity and inflammatory markers. Complete the Stop Bang questionnaire if you have not done so. Cortisol is the hormonal bridge between chronic psychological stress and metabolic syndrome. Chronically elevated cortisol promotes visceral fat deposition through direct effects on adipocyte differentiation, drives insulin resistance through direct antagonism of insulin signaling, raises blood pressure through sympathetic activation, and disrupts sleep, worsening every other component of metabolic syndrome simultaneously. Structured stress management, including device-guided slow breathing, mindfulness-based stress reduction, regular nature exposure, and addressing the chronic stressors themselves, produces measurable reductions in cortisol and improvements in metabolic markers. This is not a soft recommendation. It is a physiologically targeted intervention. GLP-1 receptor agonists, semaglutide, tirzepatide, liraglutide, have demonstrated efficacy for metabolic syndrome through several simultaneous mechanisms. Significant weight loss targeting visceral fat specifically, direct improvement in insulin sensitivity, reduction in hepatic fat content, blood pressure reduction, and in some trials, direct anti-inflammatory effects. These medications are now approved for obesity, type 2 diabetes, and NASH in various regulatory jurisdictions, and are increasingly supported by evidence as metabolic syndrome treatments beyond their original indications. For people who have implemented consistent lifestyle changes without reaching adequate improvement across the 5 criteria, GLP-1 agonist therapy is a clinically reasonable and evidence-supported next step to discuss with your doctor. While lifestyle intervention is the cornerstone of metabolic syndrome management, medication targeting individual criteria is appropriate and evidence-based when lifestyle changes alone are insufficient. Blood pressure above 140/90 in a person already implementing lifestyle changes warrants antihypertensive treatment, preferably with an ACE inhibitor or ARB, which provide additional kidney and cardiovascular protection beyond blood pressure lowering. Elevated LDL or ApoB in the context of overall cardiovascular risk may warrant statin therapy. Impaired fasting glucose progressing toward overt diabetes warrants metformin as a first-line pharmacological intervention with additional evidence for cardiovascular protection. Treating individual criteria does not replace the imperative to address the root cause, but it reduces the organ damage occurring while the root cause is being addressed. Let me say something directly. If you recognize yourself in this video, if you have 3 or more of the 5 criteria, if the signs I described sound familiar, if multiple conditions in this series have applied to you, I want you to hear this clearly. Metabolic syndrome at any stage before advanced organ damage is reversible. Not manageable, reversible. The same visceral fat that drives all 5 criteria can be lost. The insulin resistance that underlies all of them can be restored. The blood pressure, triglycerides, glucose, and HDL that define the diagnosis can all return to healthy ranges. This happens in clinical practice every day when people apply the right interventions consistently. The conditions in this series, liver disease, blood pressure, kidneys, diabetes, heart disease, stroke, cholesterol, fatty liver, sleep apnea, are not separate misfortunes. They are chapters of the same story. Metabolic syndrome is the title. The visceral fat, insulin resistance, and chronic inflammation that drive it are the plot. And the 8 actions in this video are the intervention that rewrites the ending. You have more agency over this than you have probably been told. Use it. If this video helped connect the dots between conditions you or someone you know is managing separately, please share it. The insight that these conditions share a common cause is genuinely life-changing for people who have been treating them in isolation for years. Subscribe so you do not miss the next video, where I will be covering vitamin D deficiency, why it is far more consequential than most people realize, the signs that it is affecting your health, and the evidence on supplementation. I will see you there.